Hey, it's Jim Thomas and Dr. Michael Barnes, Mike, and our little half-hour talks, hopefully to support you either as a person struggling or a family member, and also clinicians programs in dealing with addiction, which is not getting any less common out there in the world.
That's for sure.
And we were talking last time about kind of reframing what we often call codependence or co-addiction in emotional connection terms and in emotional bond or attachment terms to say that these are probably caring behaviors. And I think that's one way I think about it.
Sure.
And we have a caretaking system. Just think how the addiction field sometimes gets, caretaking bad, and boundaries and distance good. And there's reasons for this, right? We know that people can get really run through a lot of pain in relationship with someone who's struggling. And in that conversation, we were talking about looking at some behaviors as sort of like prodependent or codependent, as we are all emotionally dependent on each other. Sue Johnson, who I really love in a book called Love Sense, talks about emotional dependence is neither weakness nor immature. It is our greatest strength. We are limbic system, social mammals. We have this powerful emotional brain, and we do best when we're accepted and belong and cared for and can care for as adults, right? And you were starting to talk about what are ways that we can get beyond sort of just psychoeducation, saying to people, hey, by the way, here's a cool quote from, opposite of addiction isn't sobriety, it's connection. What does that mean? What do programs do? What can clinicians do? And how can families, understand this in a way they can maybe go out and try some different things, right? Instead of either pulling away or lecturing or what we, would call like rescuing or something. Yeah.
It's interesting. I think when I think about treatment, I mean, we get families when they're at their, so often they're at a point of respite. Their loved one is now in treatment. They can take a breath, and they sometimes seem almost disinterested. Can you just give me a couple days to just breathe and then I'll come in? Or we get them in the middle of a trauma response where they're angry and they're hypervigilant and they're frustrated. And I think that I've been doing a lot of presentations on trauma integrated addiction treatment. And one of the things that I said is, if you're going to do that, your family program has to be trauma integrated as well.
Right.
And they're not in most cases.
There's so many. Yeah.
Yeah.
It's a good question people should be asking, if you're going to go to a program, tell me about trauma integration. Tell me about your understanding of the importance of these relationships in this person's life. Tell me about your understanding of attachment theory. How do you work with shame, which is comes with addiction so often in trauma and pulls people away from loved ones. And if they don't have cogent, comprehensive answers and they can't tell you how it's woven into their program, they say, well, we do a half hour on that at Family Weekend. I'm being a little facetious, but push. Find a place, that's going to, like the Foundry. So if you're first time listening to one of our talks, Dr. Barnes is the chief clinical officer at the Foundry up in Steamboat Springs and has worked with tons of programs. And you were with Cedar down in Denver, Colorado in the USA for a long time. And you train in Baltimore at a program consistently. You've written about this. So you know your stuff. And it's as important what you're saying. I love the way you described that, right? Folks either come in crisis, in a trauma reaction, and are demanding things of the program, and it's chaotic. And I think that's where sometimes programs just have that instinct to say, wow, you're a chaotic mess. This person coming to our program's hard enough. Can you leave them alone for a couple of weeks? Or like you said, they come in and it's like, oh my gosh, somebody else is going to care for them. I'm numbing out or shutting down or getting some respite for a few days. I've been dealing with this for, you know, X number of years or whatever. And
I mean, I'd like to have a dollar for every time I've said, so tell me again why we're frustrated by a traumatized client acting like a traumatized client. And the idea of, like, in our last discussion, you were talking about that need to connect with that person at that time is, and if it's hard to do
right,
when
right.
we're in the middle of a trauma response, and where if we can just say, it sounds like this has been really a difficult thing. I mean, clearly this has been difficult, and like
That's so essential. This is something I think, uh, you know, our passion in talking about this and having these little 20-minute, half-hour discussions and trying to infuse this more out there in the field. You said something so powerful. You know, why are we struggling with a traumatized family member, or parent, you know, a partner, spouse, or this client who's come in and, you know, into our program and they're having a, you know, 3 days in freak out. I'm good now. I don't need to be here. I've learned everything I need to learn. You know, let me go. Um, Sort of like, why, if you're working with someone depressed and you try some, you know, basic sort of, let's try to see if we can get some energy going here, and they just say, yeah, I'm just really depressed. We we try to resource ourselves and understand this person's depressed and they need us to stay in there and they need our energy and they need us to, you know, join with them. And suddenly with addiction, it's like, forget that they're traumatized, forget that they're probably ashamed. There's levels of shame, there's anger. And what you're talking about, I think, is a very core sort of humanistic stance of course, you know, like in spiritual terms, how many different spiritualities and religions and things have some message like, you know, there but for the grace of God go I. You know, if I drank this much and I'd had these childhood experiences and I was in this drama with my family, or, you know, I'd be acting this way too. If I was the dad of this person, I'd be acting this way too. So let's make sense of it instead of, you know, or
well, I think it's funny. I speak a lot on traumatized families, and I've had people come up to me afterwards and say, it's funny. I never thought about the family being traumatized, and it's, from the research. My research is in uh, families in intensive care and pediatric intensive care, and the our findings were very clear that the parents of these kids in pediatric intensive care exhibited the exact same symptoms as someone with post-traumatic stress disorder. That
right.
the longer they were in fight or flight, the more organized they became around the traumatic material and worrying about security and safety and vulnerability. And that idea of our program is set up to be trauma integrated with our clients, but not trauma integrated with our families.
It's so important what you're saying, because I think the point you made, when I hear, you know, families, and be honest, if you're out there listening, you hear families with a pediatric, you know, there's a chronic illness crisis, something like that. You can see the young person, you know, like in the ICU or something. And of course, families are traumatized. But boy, we have these leftovers around alcohol and substances from, you know, back in the day, not that long ago, that these were moral failings. These are willpower issues. You're a loser. You're a bad person. You're dysfunctional. And then we've somehow, instead of trying to make sense of it, we spread that out to the family. You're all dysfunctional. And I think about research like on, you know, there's some studies back in the day about foster parents taking on traumatized kids in the system, and that there's the social workers were likely within 3 months to be describing the foster family who's trying to adjust to this, you know, very intense kid as having dysfunctional. They're dysfunctional. And I think we do this. We're so prone to find dysfunction in our society and to label things instead of trying to understand things. And I find when I if we could go in and just ask families things like, what's it like to have your person? I worked with a couple people that are doing sort of like liaisons, educational consulting type things, helping families navigate programs. And I'm sitting in on a conversation for to gather information, and to summarize it, we're listening to a clinician deliver a very heavy report about there's two other things going on here. There's not just the use, but there's maybe a verbal processing problem, and there's a coexisting diagnosis, et cetera. And I loved when my colleague, they say, what do you want to tell the parents? What do you have to add? And he says on a Zoom call, he says, what I really want to know is what's it like for you as a mom and a dad to hear such intense, difficult information about your 20-year-old son. Could you talk about that, please? Right, coming to the lived reality that people matter to each other. And when alcohol or a substance or process comes in and starts to take somebody away from you and disorder your attachment with them, you're going to act traumatized, because it's traumatizing to lose somebody you care about, or to face the possibility of losing them. And
Absolutely.
so maybe we could say to people, what would you do if you thought about it as a pediatric emergency, as a program that everybody is just dealing with? That's their baby that's come to your program. Like in a family program, right? They held that person as an infant, and they didn't dream of, I hope you take heroin someday. I
But
hope you
that's
get lost in drinking. I hope you.
But that's one of the things that so many families talk about is the day this process started, we lost our son. And the reality is you lost the image of who you lost the relationship with that child that you had before. You lost the image or the dream that you had, when in reality that they haven't lost their son at all. Their son is right here.
Right. And it's strained, and they don't know how to reach for them and respond to them and be there for them. And I think it's simpler to just say, well, just have better boundaries, which is good to have healthy boundaries. Work your program, as it's good to work your program. Leave them alone, and it's like, boy, it's hard to do if you're a parent and you try to imagine, am I really going to distance from this person for like a month or a year or something? And I have a couple I worked with I use in training. They've given me permission, and it's so powerful because the fellow is, I've come into a program, a residential program, partners there that 3 weeks after relapsing, and we're doing a 2-day intensive. And early on in the 2 days, he says, I had my first panic attack. And I says, what was it about her? And he goes, yeah, we're allowed 2 phone calls a week. And it was 2 days after, and I had 2 days to go. And I just got scared, and I didn't know if she was okay. And I wanted to know she was well, and I didn't want to bother the program, and I just panicked. And what happened? I went in and told my boss, and what did your boss do? And I thought the boss was brilliant. He says, are you worried about your wife? He said, yeah. And he said, why don't we just sit here and send a little prayer to her? And I started breathing a little easier, right? And then he talked to the program about, is there some way I could have healthy contact and just kind of know how she's doing because I care about her? How can we use this care in a healthy, helpful way instead of cutting me off, telling me I'm controlling, telling me I'm too boom, boom, and then boy, you know the labels.
Yeah, how often, I don't know that, I don't want to make a blanket statement, but I think about marriage and family, the faculties that I've been on in marriage and family programs, we didn't even offer addiction courses for marriage and family, or for couple and family. And that there's, like the two treatment philosophies don't meet somewhere in the middle. And you hear interventionists come in and say, when they drop off a client, I just brought you the healthiest member of this family, and not understanding systems theory and how positive and negative feedback and
Right.
the recursive nature of things. And I think there's a part of until the family is the client, I think we're always going to wrestle with this issue.
So that'd be one piece of advice for a program or clinician is look at the whole family. I think about that too in attachment terms. About I like to call it their attachment reservoir rather than history. What's in this person's sort of reservoir of relational experiences, and where's family fit in and friends fit in, and like fellowship if they're doing 12 steps, where does their, I have a guy that I work with or person I work with that really gets it, but I want to know like who's there that cares about you and what's happening in those relationships, and see that it's a whole. I love that idea of if we could all just remember it's one person sitting in front of us, but it's a whole like posse of people, a whole kinship connection, a network, however you want to think about it, a family that are both impacted by and connections gotten complicated because substances tend to make it more difficult to be close to somebody often.
Well, and since the system doesn't really support family therapy very much, in traditional addiction treatment, we have actually started a multidisciplinary treatment team meeting on a different day than our multidisciplinary treatment team meeting that is really all about the family. And so, and it's the only program I've ever been around where family work took as a central of influence with the primary therapists and with the counselors and techs and et cetera, that it's not just looking at how the family either helps or hinders, but understanding the relational aspects that this person comes in with, but then also is facing on their way out.
That's right. And get them in from the beginning. Well, that's and Amanda, last name Thomas. We're not related. Amanda Thomas and I have been going into these programs with some like Ascend Recovery and Even Square and play, and Momentum, Lean In. I'm just I won't remember all the names. I apologize to those programs, but and what's happening when clinicians go in and visit their own experience in training, what's your attachment reservoir? Who did you bring with you to this training? Who empowers you and uplifts you? And you're like, if you saw them at the hospital, if you woke up in the hospital and they were there, it would be like a comfort. And where is their tension? Where is their difficulty? And where is their distance? And they live into that and then say, it's the same for the person showing up. It's the same. And they come in with these connections, and they're going to go back to those connections. And even if they emotionally cut off, as Bowen used to say, and they stay in Salt Lake City and they don't go back to Ohio or they don't go back to North Carolina or Florida, that's not like they're not going to have that family. And so let's work with the family. And I like what you said, make it central, make it, we have the structure, we're slowing them down. It helps them, the traumatized and addicted brain slow down. They start to get some executive functioning back. They start learning some skills. But if those skills don't translate to connection, then they go out there and they're alone. They're white knuckling it. Eventually, they're going to go back for Thanksgiving or something. And if the same old systemic trauma, it doesn't mean they'll relapse, but they're still alone. So I like that idea. One, make the family central and see. So for me, the second would be embrace the family as they are and get to know them. Don't start telling the family how dysfunctional they are and how they're co-addicted and they're codependent and stuff. If you can say to people, of course, you kept bailing them out. You love them and you were scared. Like you said in our last talk, you're having a trauma reaction. If I don't pay their rent, they'll be out on the street. So how can I help you with that? so you can stay connected and be with this person. So, and then I think, can we get in with people in therapy situations and sit with families? And now with Zoom and things, this is easier to do. They don't always have to fly to the program, to do a long weekend. Let's get the family together and talk about how were relationships before the substance showed up. What's playing out in the same way it played out back in the day? What's changed? And how can we bring you all together and have a healthier, experience of each other, and not say, after this person's been sober for a long time, then they can go back and try to be with their family. It's not the way most people work. They go back.
Well, it's interesting. You've seen Jelinek's chart, and I have a slide that I use with half of Jelinek's chart that has all the progressive symptoms of the disorder, and then I have a family, like a mobile over a baby's crib that I represent as the system.
Mm.
And I ask families, so as this person was kind of getting more progressed, how did you adjust to try to solve that?
Yeah.
And that then when they get to the end of that and they begin to realize, wow, we have been slowly making lots of changes that we weren't even aware that we were making. And that, because they'll always say to me, if they just get sober, then we'll go back to normal. And I always say that normal sailed a long time ago. Like, you're living in a new normal. And
right.
And that idea of how do we as a, so we're in the process, I'm in the process of writing a new family program right now that's going to be almost like an intensive outpatient program for clients and their families.
Nice.
And so I'm really kind of, this conversation is really helpful to me as I kind of think about, like, what is the difference that's going to make a difference in that joining and starting that process in a way that's different than the traditional way of dividing, and you have your work to do and you have your work to do, as opposed to, so what's it like to be a family sitting in this Zoom conference room right now?
Yeah, and if one of you's in a residential program in Utah or Steamboat Springs, Colorado, or Florida, or in a sense the whole family is, you're all being impacted by it. What are you doing? How is it impacting you? What are your core emotional responses about this? Not just your thoughts about it. Who's scared? Who's shutting down and numbing out? Don't want to deal with this anymore. Who's sad? Where's loneliness in this family? How does this? And I go back to some of those old family therapists. They'd ask these questions right away. Like, how does this family deal with loneliness? Who in this family can tell me, has a clear memory as a little person, that an adult would come to you, that you at least once, a parent, an aunt, an uncle, a grandparent, a foster parent, somebody who bent down and said, Mike, how you doing in there, little person? How are the other kids treating you? What makes you excited? What have you been sad about? What are you scared about? How are you doing? Right before this conversation, my daughter comes out of the law school final, like, oh my God, I think I might have screwed this up, and she's scared, right? And telling me about it. And I'm like, oh, I can relate to that. I can relate to being scared, and she calls some friends. They're like, no, I made the same mistake. We'll be fine. She soothes. What she does, she goes out, she resources herself. It's so hard when it's substances because we call, and if the family doesn't get it, that the long lost prodigal son or daughter calls, 3 years in or something, and says, Dad, can we talk? What's going on? I've been using again. What's the heart want to hear? What do we want the dad to know? The most important thing, Dad, is they called. They called in their loneliest place. I'm really, really impacted by Mr. Rogers. I sometimes when I'm training therapists, I talk about my favorite humanist of the 20th century was Rogers. And I don't say Carl, I say Mr. Rogers, you know. And there's a book, I'm so proud of you. And a long story short, you know, this journalist from Texas becomes friends with Fred after writing an article about him. And he's also an active alcoholic and depressive, and his marriage is falling apart. And he doesn't really, he tells Fred a little bit about it at times, etc. And he's very suicidal one day, and he emails Fred and says, I'm going to take my life. Probably by the time you get this email, I would have already done it. And you're not going to be able to stop me, so don't call the police or anything. And he's making his preparations when about, 20 minutes later, he hears the little ding, and he's like, it's Fred. He's responded. And now he has dumped all this shame and stuff. And what Fred says is, in the header is, I'm so proud of you. And he's like, oh, fuck, I got to read this. And he says something so powerful. I'll never forget that I think about working with families and people in addiction and trauma. He says, I'm so proud of you. In your darkest moment, when you have convinced yourself, I'm paraphrasing, right? When you convinced yourself that your wife and your children would be better off without you, that the load is too big to carry, the pain is too great, the shame is so huge, that you thought of your friend Fred and you reached out to say goodbye. I want to tell you what you've meant to me. And he talks about what he's meant to him. He closes with, I'm so proud of you. And if you are reading this email, it means you're still alive. Would you do me the greatest honor and call me before you die? And of course, he's like, I can't kill myself. Mr. Rogers just told me I'm proud. Because if we could say to people, I was training a bunch of therapists in this EFT, emotionally focused attachment therapy. And one of the people, I'll keep it anonymous, we were at a program, they were hosting us, and this person had been in that program. A lot of people that go in to become therapists and counselors that struggle, right? And they said something very powerful. On like the third day, they open up and they start crying, and they say, Jim told that Mr. Rogers story, and when I came here, when I was picked up at the airport all strung out, the person who picked me up was so nice. And then when I pull up, and the missions lady came out and gave me this big hug and said, I'm so glad you're here. I want you to know, even though I don't know you, I'm proud of you for taking this step into the unknown. Then the very next day, I think, or that night, I thought, these programs, they have all this, they're going to cut me off from my family. Would you like to call your mom and dad and just let them know you're safe? They structured the conversation for me. I only talked to them about 5 minutes before they could panic. And they called and I told them I'm safe. And they said, we're so glad. And then to start the journey there, we're proud of you. We're glad you're here. We love your family too. Nobody's in trouble. There's accountability. You can't sneak drugs into our program. We have rules. It's not like those things are absent, right? So how do we do that? We got to keep talking about this, I think, Mike.
Yeah, I think so. It's interesting. Families will say, I just wish my loved one would be honest with me. And I would say, well, are you sure? Like,
you want to know all the details.
Let's talk about that for a second. And I talk about the idea of what if the truth is they're really close to using and they're really struggling and they are in a state of despair. And what would you say to them? And they begin to realize that they are so programmed to give them advice, programmed to take charge. And then we can have that discussion that says, maybe there's some other things that you can say.
Yeah.
Like, I know you've been doing so well, and I know you'll continue to do it.
I'm glad you called.
Yeah.
I'm glad you're talking to me. As long as you're talking to me, you're not using. I was thinking about you yesterday and how much when you're a kid you love teddy bears. That's funny, Mom. I haven't thought about teddy bears in a long time. Whatever it is, just be engaged Stop being surprised that your person who struggles might call you at random late at night and say, I'm struggling. And maybe we could lean into, I'm glad you called. And then we can resource and help the family with, that's a tough call to get.
Yeah.
It's kind of like, I had one family that says, imagine that your son has called you 6 times to say, I've got cancer again. Oh, it's back. I got a new one. That's when he went from marijuana to meth. It's back. And us to all understand that it's a scourge, on connection. It's if you get lost in this stuff and it hijacks the part of your brain that's wired to connect, it's traumatizing for everyone. It's lonely, fosters loneliness in the whole system. I like your reminders to remember there's a whole system, a whole family. And how can we bring them into the room and into the work in a way that's an attachment emotional resource, not we're trying to contain them and teach them in a way that's not experiential. And if it's not experience, if I don't have an experience, I'm going to go back to old behaviors. We know that in the field, right?
Yeah, I think that as a field, we have to lose the false dichotomy of client and family. The client is in the family, and that maintaining that, I think it's a big ask to change the whole industry, but I do think that there is a place for this kind of discussion within family programs to begin to look at how do
I'd be interested to see what you do with your family program, right? We need people like you doing this. And I'm trying to do it in my outpatient practice and trainings and even clients. It's interesting. I think about my couples and my families and the people who come to see me. That Bill or, Leroy and Jenna or Juanita and Shayna or young Billy and his mom and dad came to see me, and they're people and I'm a person and I want to be the Foreign Legion. This is the last stop. I'll come here, I'll fight, I'll do my best, and I'll be fighting for you and your relationship and your well-being, including your relationship to yourself, even if you walk out the door and tell me to F off. Maybe that's how we think about the programs. That's what you're doing. And if we brace the whole family, then they're more likely to stay and do good work.
I agree. So let's keep the conversation going then.
Yeah, next time we could talk about some specific sort of, for families and clinicians and stuff, just moves you can make as you engage with the family. You started to hint at some of them, talking about how that admissions person greeted this person who came. I'm glad you're here. We're proud of you. What do you need right now? Oh, and why don't we have you call your family and tell them you're here and you're safe, and let's start having you have because I think people need ideas, because the dominant discourse is about boundaries. Work your program. I work my program. You're co-addict. You're dysfunctional.
In a world of COVID, where no one can come to the treatment center except the client, we sort of miss that opportunity even more now that the person gets in a car and they're alone, coming up the mountain to Steamboat, and the use of technology and getting better with that. And
well, there's our next talk.
Yeah, it's a big part of it.
You start talking about how you use it. I'll talk about how I use it and what I know programs are doing, so that we're not limited by those COVID physical realities. And COVID's another. It is isolating people and increasing people's likelihood of relapse. Or
I think it's impacting staff too.
Yeah.
So always good to talk to you.
Yeah, good to talk to you, Doc.
And look forward to doing this again.
Yes.
Talk to you later.